So good afternoon everyone. We will start a new topic, that is respiratory system related diseases and their treatments. So in that what we can do is we have got various diseases in the respiratory system. Very common, very known are the bronchial asthma and emphysema, apart from other small one, that is cough, cold, etc. As such, we have discussed many things in pharmacology, and what we have to do here is the pathophysiology and diagnosis. We will go for diagnosis first. The most important diagnostic tool which is available for this bronchial asthma is called as a spirometry, or it is using spirometer is an instrument which is used for that, and that is, I hope, have you studied it, have you seen it in APHE, various respiratory volumes and capacities? Can anybody tell me something about? Already I told you to go through this. Can anybody tell me something about it? No answers? Those who know can unmute yourself and can give answer. Yes, tidal volume. Then what is tidal volume?
Volume of air inspired is known as tidal volume. 500 ml असतं.
But okay. What is IRV? What is ERV?
Inspired reserve volume.
Okay, good.
Inspiratory reserve volume and expiratory reserve volume.
How these are measured? How these volumes are measured? How this tidal volume or ERV or IRV, how they are measured?
Spirometry.
Okay.
With the help of spirometry.
Very good. So we will discuss about spirometry, what are various things, and we'll rush fast, and then we'll see various diagnostic features of various situations. So you know about spirometry. So it is a non-invasive method of evaluation of pulmonary function. It is simple, cost effective, it is accessible, and it is not giving definite diagnosis, but it helps in making diagnostic with other diagnostic methods like chest X-ray and all other methods we are using. In addition to that, this is also helping. So this is not the only method, it is additional method along with other methods. So what are there? It is evaluating the symptom signs of abnormality laboratory tests. Suppose there are some tests which indicates there is some respiratory problem, then it helps it measure the effect of disease on the pulmonary function. It screen the individual at risk for having pulmonary disease. It assesses the pre-operative risk. Then it checks the prognosis, particularly if already respiratory disease is there. It assesses the health status before beginning the strenuous physical activity program. So it also used for monitoring the therapeutic end. Suppose we are giving treatment, whether it is working properly or not, that helps it into it. Then it gives the course of disease that affect lung function. It monitors the people exposed to various agents which are affecting pulmonary function, and it monitor the adverse reaction of the drug having pulmonary toxicity. And apart from that, it is useful into checking the disability impairment of the these functions. And also in public health, epidemiological surveys, deviation of the respiratory reference equations, and clinical research it is used. So it is used in, will not go for where it is used, various fitness for duty examination, and then medical surveillance program in various condition where the persons are at risk of developing occupational related respiratory problems. So asbestos, cadmium, coal, this coke, where these emissions are there, or cotton dust is there, where person may get chance of having respiratory problem. In that it is there. Then in tertiary prevention in various diseases like restrictive, obstructive, or combined ventilatory defects are there. In that for screening we are using. Where we cannot use spirometry, when there is uncontrolled hypertension is there, in that we do not use, or we should not use spirometry. Suspected presence of active tuberculosis or other communicable diseases, in that it is not used. Thoracical or abdominal surgery within recent 3 weeks, it is there. There is a myocardial infarction or unstable angina within last 6 weeks, it is not used. In respiratory distress, that is respiratory system is depressed too much, it is not. Active hemoptysis, that is blood is coming in the cough, in that it should not be used. Recent eye or ear surgery or eardrum perforation, because it gives pressure on that, it should not be used. Abdominal or thoracic aortic aneurysm is there. I told you aneurysm earlier also, that is, it is a reduction in the, or it is thinning of the wall of the artery. The wall of the artery becomes thinner than normal one, that is aneurysm. In other condition, when already common cold is there 3 days ago, it should not be used. Severe respiratory infection in last 3 weeks, it should not be used. If somebody has had a smoking in last 1 hour, should not be used. If somebody has taken heavy food, should not be used. And somebody is on the bronchodilator use, it should not be used. What are the complications it may cause? It may cause chest pain, syncope, increase in this intracranial pressure, paroxysmal coughing, nosocomial infection, bronchospasm. It can this type of complication it can result into. So what are the various volumes and capacity? Let us go one by one. One is tidal volume. It is the volume of air inhaled and exhaled both. Okay, SABA and all. So it is inhaled and exhaled at each breath during normal or quiet breathing. That is called as a total tidal volume. Then this inspiratory reserve, maximum amount air that can be inhaled after normal inhalation. Expiratory, that is volume of air that can be forcefully expired following a normal quiet expiration. Then this residual volume air remaining in the lungs after forceful expiration. So these are various. Then what are capacity? That is total lung capacity, total volume of the air which is occupied inside the lung. Then vital capacity is very important, the maximum amount that can be exhaled after the fullest inspiration possible. Then this force reserve capacity, amount of air remaining in the lungs after a normal quiet expiration, that is and inspiratory capacity, maximum of air that can be inhaled after the end tidal position. So we shall see one by one graphical presentation. So this is what total lung capacity, that is maximum one. Then we shall see one by one what it is. Resting expiratory level, how much it is normally, how much it is causing. when it is taken how much maximum it can reach, then we'll call it as a maximum inspiratory layer, and again maximum expiratory layer. So when it is forceful we are doing, that is maximum inspiratory and expiratory we are reaching, then we'll call it as a vital capacity. That is, it is the difference between maximal inspiratory level and maximal expiratory layer. Then again we can have this the normal respiratory which is going, that is we call it as a respiration rate. Then when we do it forcefully, then we call it as a expiratory reserve volume, and again forceful expiration we call it as a expiratory reserve volume. Then this is from the normal one, this is the vital capacity. Sorry, this is the tidal volume during the normal inhalation, and this Vt is a tidal volume. Then tidal volume plus IRV becomes this inspiratory capacity, and this plus this becomes the expiratory reserve one. And when this two you are making, that it becomes the forced respiratory capacity, and this is a total, that is total lung capacity. So this graph is very, very important, that helps us in various this one. Now we shall see what are the importance of each. FVC is a forced vital capacity. Then one more important term which will be coming in asthma and emphysema is forced expiratory volume in first second. So when expiration is doing, when the air is expired, or at that time forcefully when we are doing, so in first second how much it is there, that is called as a first expiratory volume in 1 second. Then it is expressed as a percentage of the forced vital capacity. So always this tool is taken FE1, that is forced expiratory volume 1 divided by forced vital capacity, and percent of it is taken as a diagnostic mean. Then mean force expiratory flow during the middle, that is called as a FEF, that is force expiratory flow. Force expiratory flow during middle half of the force vital capacity, that is taken as a at 25 to 75%. This is taken as a tool. So one by one, force this vital capacity is the maximal amount of the air that can be exhaled forcefully after maximal inspiration, or the most air the person can blow out after taking the deepest possible breath. So take a deep breath, forceful breath beyond vital, beyond tidal volume, and then expire it, and then measure this, how much volume of air was expired. So it defines maximum volume which is exchangeable air in the lung, that is vital capacity. The force expiratory breathing, it helps into understand. Then it requires a muscular effort, and some patient training is required in that. The healthy FVC values are approximately 4 liters, and it slowly diminishes with the either normal aging also and with various diseases. Significantly reduce force this vital capacity, that suggests damage to lung parenchyma, restrictive lung diseases, that is fibrosis, etc., loss of functional alveolar tissues, that is example is atelectasis. These are various diseases. They are giving idea about it. There are variation are there age wise. We have seen that in older people it reduces, in females it is less. Height, if it is less, then it can be less. Ethnicity, in like Asians, Caucasians, Eurasians, etc., in that there are variations. Some are having some more, some are having less. So accordingly we should have adjustments. The next is FE1, very popular, that is force volume air, that is in the first second of force expiratory maneuver. That is when one is tried to forcefully expire the air, in first second what it is there. Normal FE is around 3 liters. Then we have got this ratio percent, that is FE1 by FVC. This value expresses the volume of air the worker exhales in the 1 second as a percent of the total volume of air. It is calculated by using the largest valued FEA1 and the largest FVC, even they are not from the same tracing. So find the largest value. So there are 3-4 readings or multiple readings are taken, and then take the largest FE1, take the largest FVC, divide FE1 by FVC and multiply it by 100 to obtain percent one. Then another one is FEF, that is force expiratory flow, that is how much it is, and in the middle actually. So it is the mean expiratory flow during the middle half of the FVC. So when FVC is being done, FVC is clear now. What is FVC? That is force vital capacity, and in that we are expiring air very forcefully. It is more sensitive than FE1 this measurement. It is considerably more variable than FVC and FE1, and these various agencies, they are recommending that only to be considered after determining presence and clinical severity of the impairment, and should not be used to diagnose disease in the individual patient. Then next is PAF, that is peak expiratory flow rate. It measures airflow limitations in the large airways. So particularly these are the again important diagnostic tool for our bronchial asthma and emphysema like disease. PF measurement recommend for asthma management. As I told you, spirometry is recommended to help to make the diagnosis of asthma. PF is not recommended to evaluate patient for COPD. It cannot measure the small way airflow limitations. What are the advantages? It measures within a minute, 3 short breaths it can do it. It uses simple, safe and handheld devices that are typical. It costs very less, that is around in US $20, that means around 20 multiplied by 100 suppose, so maximum 2,000 rupees. Disadvantages are there if we compare to spirometry. They are insensitive to obstruction of small airway, that is mid or early obstruction. It is very dependent on the patient effort. So some patient to patient variables, if some are doing in good force, some are not applying that much force, so big variation it can be there. Mechanical PF meters are less accurate than spirometer. So these are the limitations which are having. So these are various mechanical spirometers are there, or PF meters are there, which are measuring the peak flows, that is peak expiratory flows are measured, and these are various instruments. They are electronic spirometer like, where one mouthpiece is there, where you can start measurement. If you are adding any medication, you can put it, the chip will be there, it will calculate it, and accordingly it can be there. This was the original one, which was spring type of old meter, and so there are various equipments like that. So what are the most important parameter is, we have seen FE1, FVC, then peak expiratory flow, then force expiratory flow at 25 to 75, and next is important FE1 to FVC ratio and its percentage wise. Then this the curve of volume to time and flow to volume loop. These are two important. We shall see this. These are very important curves. So this is first curve, that is FE1, FVC and FE1 on a normal volume time curve. This is volume versus, we have seen, see again VT curve, this volume to time curve, and flow to volume loop. These are two important things. After all this data, it can be put into graphical form. So this is what, see, this is time and volume. So as soon as person start, this will be measured. This is a volume increasing, it reaches to around 3.8, so it is called as a 3.44, sorry, and this is 3.89. So it is around, we have seen already it is around 80% to 90% is FE1. So this is the data which is there. Okay. The tracing begin at 0.2 seconds. So here it is done at 1.2 seconds. That was actually measurement. Now another is graph. I told you FE graph, isn't it? Just now we have seen FV loop. So let us see what is FV loop. That is flow, liters per second. At what flow the air is coming in the machine, that is measured, and how much volume has come out. So these two things are there, and here we found that FEC was 3.8 from same person. Again here it was FEC 3.89, again it is 3.89%, and this curve has shown that what is the flow rate. So initially it was the highest one, and then gradually it comes down, because initially it is the maximum one. Lungs are fully stretched at that time, full air has taken, so it comes very fast and it increases. Once the peak is attained, then slowly it will come down, and then it will be gradually, flow will be zero, that will be the end. Now these two curves are mixed together, and accordingly we can have, that is flow versus volume. So at inspiration what happens, or expiration and inspiration. So at expiration, because air is coming to meter, okay, so you will find that it is increasing, and at inspiration it is minus figure, because you are taking air from the machine, so it is minus. So what happens, here you are making it, here you have this peak expiratory flow, here you have reached to the maximum one, that is FPEF, and slowly then after that peak the force is gradually decreasing. So after that you are measuring at 25%, then FE, that is force expiratory flow, at 50%, at 75%, you can have at 25% also. So from that you are measuring one by one, and that gives you value of FEF, that is force expiratory flow. Okay. Then this is the total volume. So this total volume becomes this force vital capacity, and this gives you the, this is the peak inspiratory flow, and slowly that inspiration is there. So this typical curve that helps, you will find, if you refer now book, you will understand from this that how these curves are taken, and these curves you will find it in various books including DPRO etc. How there are differences they are taking, we shall see this also later, how there are differences that are taking place in various diseases, and this is how this is a normal curve we are seeing. Then we get this spirometric flow diagram. This is the normal spirometric flow diagram. A is there, where you get this kind of flow, and the flow is there, and volumes are there. So this is exhalation, again below is inhalation, and we are matching with again this volume versus time graph, and we are measuring at FE1. Here also we are getting FE1 in the graph. This is peak expiratory flow, and in once how much it is there, we have seen that it is almost 80% to total volume. Okay. So this is FE, here also we have got it, and on that basis we are measuring it, how it is coming. Will not go for these details. Only thing that equipment should be checked, it should be calibrated. Whatsoever contraindication we have mentioned earlier should not be there. Any interfering condition like cold or infection should not be there. Age, height, race, gender, all data you should have, because again you have to make appropriate calculations. Selections of appropriate reference value for that, because for age, for height, for race, gender, this reference value will be available, and accordingly you should use it. Then check about patients, whether patient is doing it correctly or not, whether we'll see some of the figures about it. Check out the acceptability criteria, check the reproducibility criteria, because if the patient is doing correctly, then we can accept it. Then if it is reproducible, If it is done 2 times, 3 times, 4 times, and every time results are coming same, then we are accepting it. Select the best curve and the best result and make the interpretation from it. So you are all performing it. This is the flow chart of the activities, and accordingly we are going for. So these are the machines and how you are adjusting it. Perform this maneuver, check it. If it is okay, then go ahead, otherwise forget about it. So what are the procedure? I will not go for more details. Explain the test, check the calibration, explain the test, prepare the subject, inform everything, get the history, whether smoking, everything is not there, measure the weight, height without shoes, wash hands, and instruct and demonstrate the test to the subject. Ask them to have correct posture, straight posture, head slightly elevated, inhale rapidly and completely. These are all instructions are there. Position of the mouthpiece, it should be open. Exhale with the maximal force. These all instruction you are giving. Then perform maneuver with the closed circuit method. Have subject assume the correct posture. It should then attach all the machine accordingly and go for it. Then what are the positions? See, these are the correct positions. Slightly the neck is slightly, or the head is slightly tilted upside. It should not be down or exactly straight. Mouthpiece should be around this one, just like blowing pipe, and it should not be just lips are blowing it like that. So check it all the things whether correct or not, and then you go for the various results which are there. If 3 reports are obtained, 3 spirograms are obtained, then you go for the correct one and accordingly use it. What is the good start of test? Must be quick and forceful, no excessive hesitation, best evaluated using the flow volume tracing. So flow to volume, we have seen it above. This both dual graph it is there for expiration and for inspiration. There are 2 graphs are there. No excessive back extrapolated volume is there. So this is volume with time. The blue line gives a good one, it's correct one. Then if it is back extrapolation, that is BEV, or it is also called as a extra volume is there, or extrapolated volume is there. So if it is there, then that has to be checked. So this volume time curve is there. You are checking about FEC, FE1, and Vtex is 0.6, that is 9.8%. That is another tool it is giving. See that there is no coughing during first 1 second, because we are measuring it in 1 second. The FE1, if coughing is there, it will disturb the readings. Some patient do cough near the end of each test, and then you can have see this type of curve you can get because of the coughing. The second one, okay, and then accordingly it can be set up with the machine accordingly. If cough is there, then it will appear in that, and then you have to adjust it. Just before 1 second there was a cough there, then on the basis of the slope of that graph, you can make it a computerized graph from that, so that it can be corrected. The flow should not be variable, it should be maximal and consistent through the testing. Volume time and flow volume tracing should be smooth. So these are the smooth one where no variable, but if there are variable, you can see the graph below. So there are these variations are there, and this shows the problem. Okay, so see here first one shows early termination. It is the glottis closure is there. In second also it is a glottis closure. It is a volume time, and this is the flow volume. So in early termination here it will make this kind of changes. So these are signs which shows changes. So no early termination or effort should be there. If effort are earlier stop, then these are the normal curve, and you will get different curves from that. Messages related to patient, if it is there, if this BEV, that is the extrapolated volume is there, that is if it is greater than 150 ml, that means you should give that, don't hesitate, because patient hesitated after beginning the expiration. Blast out faster when this peak flow time is less than 120 millisecond, greater than 120 millisecond. Then effort to produce maximal peak flow was not sufficient. So these are various things which has to be maintained, and accordingly once this idea is there, the patient can be guided. These are the quality check for how manure means how the patient is doing it, what is the way he is doing it, and accordingly check it. These are the parameters, and if you find it correct, this much details will not be asked, don't worry about it. We'll go directly slowly about various figures about it. Spirometry can cause bronchospasm. So each effort gets work, patient eventually reaches to plateau, and then you have to stop it, you have to take it after some time. So we call it as a spirometry induced bronchospasm. So every time it is causing decrease in the volume, and then accordingly you have to take care. Report the largest FEC by FEV, and if they are not available from same stressing, then still what's your available 3-4 readings you have got, from that you can do it. Will not go for this, various errors will not see. So these are various good curves are there. Good effort, small, then weak push, tongue in the mouthpiece, all these graph will be appearing, and from that the expert or the spirometric technician can guide the person that what they should not do or what they should do. So again, good effort, early termination, and glottis closures, these are various extra breath, all this will appear on that, and this has to be removed. Then next is race, gender, height, age, etc. These are all their example. Caucasian for Iranian race, you have to take the volumes. So these are various reference values which are available from the data which is there. Height, age, what is the FEC, it should be there, what should be FE1, okay, and all this data you will get. These are the ready-made charts for different ethnic groups will be available, for males, for females, like that it will be available, and from that one can think what should be for each country, or this is Caucasian means particularly Iranian race, but there can be for Asians, it can be for Europeans, Americans, Africans, accordingly different race wise we can have different volumes. So these are the predicted normal values are there, and now this spirometry will help the person to go for the correct one. We shall discuss now other this one, how this spirometry is used, because we have just seen how the spirometry done, what are the various measures, and what are various capacities, volumes are checked. Now when we will go for the next, that is we will go for various activities. What should be the apart from this spirometry, what are the tools which we are going to use, and from these tools what knowledge, what information we get, how we can differentiate between bronchial asthma and these other COPDs. So these are giving us, this will give us a diagnostic feature, and from that one can because basically in both cases in COPDs, even that way bronchial asthma is also COPD, but bronchial asthma is clarified, it has got a very clear signs, symptoms, and this one, but in both cases there is hypoxia, in both cases there is a decrease in the oxygen carrying capacity, and in that case we have to understand how it is, what is the difference, and then we can go for its treatment accordingly. So I hope you can go through it. If you have any difficulties, you can ask, read this topic, and you can ask the difficulties. About syllabus, you can discuss it on your group. You make it final, but see that 3 equal topics are coming. Huh? हा नाही झालं, बोला काय म्हणताय. अरे मी आत्ताच दिलं आनंदला पैसे आज. माझ्या खिशात जेवढे होते, त्यांनी 500 मागितले, माझ्या खिशात 400 होते, मी सगळे दिले त्यांना. आनंद विचार, आनंदच दिले मी आज. अरे नाही, काय झालं माझ्या खिशात ॲक्च्युली आजकाल ते काढणं चालतं ना, मी खिशात पैसे कमी आणतो. तर आनंद सकाळी आला, आनंद म्हटलं की सर मला काहीतरी द्या पैसे, तर आनंद 400 रुपये आज दिले.